words about Dr. Chaitanya. And we are three of us here who are sitting here are the students of Dr. Chaitanya, like me, Miss Mary Reggie, and Dr. Shanta Maria, who attended the diabetes educator classes with Sir. He has a deep-rooted knowledge in the subject, and you'll all enjoy his class because the knowledge with fun he'll be sharing with all of us. So you can hear, and the doubts you can keep it, because today slightly we are delayed. So you can keep your questions and doubts, so that tomorrow when we join a little early, definitely, all questions, whatever you have to, get the doubts cleared about, definitely doctor will clear your doubts. Okay. So with this informal introduction, I move on to, I request Lakshmi to introduce him formally. Over to Lakshmi.
Thank you, ma'am. Good evening, all. It's my pleasure to introduce the speaker for the day, Dr. Chaitanya Murthy K. So as starting the introduction, even I would like to tell three of Sir's students are here, Vali ma'am, Shanta ma'am, and Mary ma'am. Through them only, even I am also familiar with Sir, hearing about all the class regarding diabetes and all. Even I wanted to do the course in between only all this pandemic started. So I hope, next time, definitely I'll try to attend the session. So Sir's area of interest is diabetes in the young, MODY, diabetic foot, type 1 DM, LADA, GDM, AGP, etc. And his professional experience, right now he's a consultant and managing partner of EKAA Hospital, Multi-Speciality Hospital, Indiranagar, Bangalore, have successfully treated more than 8,000 patients suffering from diabetes. And his professional experience include, he was consultant in charge for Dr. Mohan's Diabetic Specialty Center, Indiranagar, Bangalore. And he also worked for the Department of Endocrinology, CMC Vellore, Christian Medical College, Vellore, Tamil Nadu. He has done his education MBBS from Andhra Medical College, King George Hospital, Visakhapatnam, and did his internship from the same hospital, and had a postgraduate fellowship in diabetes from Christian Medical College, Vellore, Tamil Nadu. And his postgraduate research work include metabolic characteristics of lean diabetes in rural and semi-urban India by hyperinsulinic euglycemic clamp technique from Department of Endocrinology of Diabetes and Metabolism, CMC, Vellore. He also has, one second, ma'am. Sorry for the interruption. Yeah. He also have a lot of publications to his credit. He co-authored chapter number 2, Diabolical Diabetes in the book, which is named Clinical Atlas in Endocrinology and Diabetes, which is published by the Department of Endocrinology, Diabetes and Metabolism, CMC Vellore. So he has, I have just given the list here. He has done a lot of presentation, oral presentation, poster presentation, publications in different national and international journals. You can just go through. And even with Mohan, Dr. V. Mohan, Best Practices in Diabetes, Optimizing Outcomes. He had one chapter, which in volume 1, Cardiodiabetology, Manoria PC by JP Publishers. So these are his publications to his credit. And his professional development, which include, that's what a lot of presentation, which includes oral presentation as well as poster presentation in CMC Vellore and other multi-speciality hospitals. And he was also a co-investigator for the HOPE-3 study in collaboration with McMaster University and St. John's Unit of Clinical Trials. He was a co-investigator in a long-term multi-centric international randomized double-blind placebo-controlled trial of the liraglutide effect and action in diabetes, which is the evaluation of cardiovascular outcome results. And he was also one of the co-investigator of Declare dapagliflozin effect on cardiovascular events, a multi-center, which was a randomized double-blind study. So a lot of studies, he was a co-investigator. You can just go through. And he received a Best Oral Presentation and Oral Presentation Award at RSSDI Hyderabad 2017, elucidation of the role of insulin secretion, insulin sensitivity, and adiposity in the pathogenesis of diabetes in Asian Indians with lean body mass index. And he's certified in good clinical practice, GCP, from NIDA Clinical Trials Network. He was a reviewer for the Journal of Diabetology, chaired a session for Satyasai Diabetic CME 2016, conducted in Puttaparthi Sri Satyasai General Hospital on 11/9/2016. He was a national speaker for ADA PAMS 2018, conducted in Bangalore. He was a trainer for National Diabetes Education Program in Bangalore in collaboration with Dr. Mohan's Diabetic Education Academy, IDF, and Indian Association of Diabetes Educators. I think all our teachers have participated in this program only. And he was a trainer for doctors from Government of Karnataka, Department of Health for National Non-Communicable Disease Program on January 22nd and 23rd, 2019. He also chaired several sessions. One was Burden of Obesity in India and its Challenges in Endoscopic Therapy for Obesity, and live workshop on endoscopic sleeve gastroplasty conducted by Manipal Hospital in Bangalore. He also chaired a session on hypothyroidism in Dialogue Symposia in 2019 and Disha Year End Diabetes Summit in 2019, which held in Bangalore. So with this introduction, I would like to invite Dr. Chaitanya Murthy for today's session. Over to you, sir.
Thank you for the introduction. It gives me immense pleasure to participate in the session and to train young minds. And I'm completely sorry for the delay that's happening because of me, because of the technical glitches. In the meanwhile, while I'm able to send the slides, I'll just start the session. And good afternoon, each and every one of you. Hope everyone is safe and healthy in this pandemic situation. Today, we will have a discussion. Actually, there is a discussion will be panned out in 3 parts. First part will be today. That is, we are going to cover the etiology, the types of diabetes, and the diagnosis. And day after tomorrow, when we meet again, we'll try to meet quite early. And we'll try to discuss the various management options that we have when it comes to diabetes mellitus. We'll even have a discussion on carbohydrate counting and various other dietary aspects of diabetes. And the last session will be on Friday or Saturday, if I'm right. On that day, we're going to discuss the complications of diabetes and the recent advances in the treatment and diagnosis of diabetes, and a brief discussion on COVID-19 and diabetes. So without wasting any time, I'm going to start the session. Please let me know if you have received the slides, and you can start sharing the slides the moment you receive. The slides will be health talk. It will be written as health talk.
Sir, I will just check and get back to you.
Yeah, sure. Okay, so coming to diabetes, why are we so much concerned about diabetes mellitus in general? It is one of the most dreadful non-communicable diseases in the world. So the problem with diabetes in India, in Indian perspective, way back in 1980s, 1960s, and 1970s, when our parents and grandparents were dealing with diabetes, at that point of time, the awareness of diabetes was very much less in India. And many of them had classical symptoms of diabetes. So what I mean to say, a person was able to identify himself or herself as having diabetes because they had the classical symptoms of diabetes mellitus. Let it be weight loss, let it be frequent urination, let it be frequent thirst, or let it be unexplained wounds and infections. So what they used to consult a doctor, the doctor used to do the basic investigations, and they used to start the treatment. Nowadays, what is happening after 2000 or 2005, the people who belong to the present generation, they don't have any of these classical symptoms of diabetes. That is really a dangerous, a warning thing for India. Why? Because there is a hypothesis by name Barker's hypothesis. So what does Barker's hypothesis state? Indians are programmed to live in a condition of famine. Like our ancestors, let it be grandfathers, great grandfathers, all those people were programmed to live in famine. So when we started moving from rural setup to urban setup, when we started moving to affluent societies, when we started eating pizza, burger, when our lifestyle has been taken for a toss, when our exercise patterns have come down, when the stress levels have gone up, we are trying to mimic the Americans. But the body is programmed to live in famine. But the lifestyle resembles Western lifestyle. So because of this, the Indians, it is called the Asian Indian phenotype. What do you
Sir,
mean by Asian? Yeah.
we got
Did you
this.
receive the slides?
Yeah, shall I share the screen?
Yeah, please go ahead.
Yes.
Thank you. Thanks a lot.
No.
Yeah. Can you go to the next slide?
Yes.
So this is what, as told by Sundarvali ma'am as well, these are the various parts of discussion. Can you go to the next slide? Next slide. Yeah, I just want to quote this. Every human being is the author of his or her own health or disease. It is aptly quoted by, it is probably quoted by Gautam Buddha long back. We are the people responsible for our own health or disease. We are the people who decide about our own diet, our own lifestyle, and our own stress. Next slide. A previous slide. We have, yeah. I just want to touch upon a few basics. What is the definition of health? In 1948, WHO, the World Health Organization, has defined health as a state of complete physical, mental, and social well-being, just not merely the absence of disease or infirmity. So this definition has been modified, and nowadays we started having various types of health, not only physical health, not only mental health, we're also having social health, financial health, and various aspects of health. Next slide. We should be proud of ourselves because Indians are the ones to pioneer health long back. Way back in 2nd century, in Charaka Samhita, there was a mention regarding the health, and there was a mention regarding various aspects of health. And you will be astonished to know one fact. Charaka and Susruta have identified 14 different types of diabetes way back in 2nd century. And the Western population, let it be the Americans, let it be the European scientists and doctors, they were able to identify only 3 types of diabetes in 1900s. So way back in 2nd century, we should be proud of our predecessors and ancestors. We were able to identify 14 different types of diabetes, but because of so many unknown reasons, the progress of health and diabetes in Indian medical system did not take a proper pace. Next slide. So what do you mean by nutrition? Nutrition, I don't need to stress upon this slide because you are better people to discuss about nutrition than me. But nutrition is a process of consuming, absorbing, assimilating various nutrients into the body. Let it be the micronutrient or let it be the macronutrient. We have 3 different extremes of nutrition. Normal nutrition, which is not usually seen. Many of us are either having overnutrition or undernutrition. Nowadays, undernutrition is coming down in India. We rarely see cases of undernutrition. Let it be anemia, let it be kwashiorkor, let it be marasmus. But we started seeing more and more cases of overnutrition. What do you mean by overnutrition? We're eating junk food. We're eating what we don't require. We're eating what uh, we don't eat what we require. So probably what is happening in India, the quality of food is getting affected. We're increasing the quantity and we are eating bad quality food. Next slide. So as you all know, there are basically 2 types of nutrients, macronutrients and micronutrients. Macronutrients are basically fat and proteins. First fuel that needs to be utilized is carbohydrate. And when a person is not able to utilize the carbohydrate, body starts utilizing fat. And when a person is not able to utilize fat, body starts utilizing protein, which is going to be the last fuel. So this cycle from carbohydrate to fat to protein happens when a person starts starving. The same thing resembles diabetes. We're going to see in the next slides. And micronutrients, we have so many micronutrients like minerals, vitamins. Now, because of COVID-19, we started left and right supplementing micronutrients to each and every patient, which is not good. Yes. So next slide. So what happens when a food is consumed? Basically, let it be the carbohydrate, let it be the fat, let it be the protein. They are digested, they are assimilated, they are converted to various energy blocks in the body. So we are going to discuss mainly about the carbohydrate physiology today. Next slide. So basically, what are the main sources of glucose? The major source of glucose to each and every person is the food. When you eat food, the food is digested, the various polysaccharides are being broken into monosaccharides, and the end product of monosaccharide will be glucose. If you even drink milk, if you even drink any starch, if you eat any sugar, all these things are converted into glucose. The same way, we have various stores of glucose in the body. Let it be the liver, let it be the muscle. So the glucose is stored as glycogen in the liver as well as in the muscle. So when the patient or when a person is not having enough glucose, exogenous glucose, when the person is not having enough food, or when a person is having a disease state like diabetes, the glycogen that is present in the body, let it be in the liver or let it be in the muscle, gets utilized. And what about the third source of glucose? Let us say the person is very lean, all the glycogen has been exhausted, has been utilized. Then body starts producing glucose from non-carbohydrate sources like amino acids. That is called gluconeogenesis, new synthesis of glucose that primarily happens in the liver and to a smaller extent in the kidney. So you remember three different sources of glucose, major source being the food, second source being the glycogen that is present in the liver and the adipose tissue, third source being the gluconeogenesis. So in diabetes, exogenous source of glucose is present, but we are not able to utilize that. Then body tries to break down the glycogen, and finally body tries to utilize the glucose from other non-carbohydrate sources. Even in spite of doing all these three things, if we're not getting energy, then body starts breaking down the fat and after that protein. Next slide. So this is what basically happens when we eat food. The food is digested in the gastrointestinal tract. Starting from mouth, we have an enzyme, salivary amylase, which starts breaking down the complex carbohydrates in the mouth itself. Then we have the stomach, which is a major grinding organ in the body. Then we have the small intestine, various areas of small intestine. The food is digested by various enzymes of the body, related by the enzymes produced by the stomach or by the pancreas. So finally, when the food is digested into small molecules or monosaccharides, that is being absorbed into the blood. And from the blood, the glucose will be shunted into the various organs of the body. To make it simple, what is basically happening in a human body? Let us say a person is having one idli. One idli is going, I'm just giving an example. One idli is going to produce 1 unit of sugar, or say glucose. The scientific term is glucose. We should not use the term sugar. 1 unit of glucose. And this glucose stimulates the pancreas to produce 1 unit of insulin. What does the insulin do? The insulin will shunt this particular glucose into the muscle and various other organs of the body. Let it be the heart, let it be the kidney, let it be the skin, let it be the intestine, let it be the brain. So we are active, we're able to do each and every activity, and lifestyle is maintained, and homeostasis maintained. But in diabetes, what happens basically initially, and one more important thing, the same insulin, apart from pushing the glucose into various internal organs, will make sure liver is not producing extra glucose. So in the previous slide, we have discussed that liver is a major source for glycogenolysis. That is, glycogen is being converted into glucose. And liver again is a major source of gluconeogenesis. So this insulin will tell the liver not to produce extra sugar or glucose. In diabetes, what is basically happening because of bad lifestyle, because of stress, because of all these aspects, the liver and muscle are being filled up with fat. That is called insulin resistance. So when there is insulin resistance, the 1 unit of insulin is not able to push this 1 unit of glucose into the body tissues, and the same 1 unit of insulin is not able to prevent the liver from producing further glucose. So the liver will produce 1 more unit of glucose. It becomes 2 units of glucose. At the same time, this 2 unit is not being utilized by the muscle. So initially, body tries to compensate. Body produces 3 units of insulin. Then this three will push the 2 units of glucose into the muscle. But there will be a time limit. Body can't keep on producing insulin, 3, 4, 5, 6 at one time, at one point of time. The insulin production suddenly drops. That is the time where the glucose levels will shoot up in the body. So in spite of having 1 unit of idli, patient is producing some 10 or 15 units of glucose. That is when we develop diabetes. Next slide. So this is how the basic physiology of pancreas and insulin. Pancreas is located in the abdomen, and pancreas has various cells. Basically, pancreas is the only organ which has an exocrine function and endocrine function. The endocrine part of the pancreas has alpha cell, beta cell, and the other cells. Mainly the beta cell is the one which is producing insulin. Alpha cell is the one which is producing glucagon. Insulin is an anabolic hormone. What do you mean by anabolic hormone? Insulin is shunting the glucose into the body tissues. Insulin will convert glucose to glycogen. Insulin will convert glucose to fat. So these are the various fuels. Let it be the glycogen, fat, protein, and insulin is the one which will convert glucose into amino acids. So various major fuels are being stored in the body. The muscle tissue will increase, adipose tissue will increase. So it is building up the body. Whereas glucagon acts exactly opposite to insulin. Glucagon will break down glycogen to glucose. It will break down the fat into glucose. It will convert the protein into glucose, that is gluconeogenesis. So glucagon is an catabolic hormone. That is the reason if a mother is having uncontrolled diabetes and if she becomes pregnant and if the sugars are not under control, the excess of sugar that is present in the mother will cross the placenta, will enter into the fetus. What happens in the fetus? But the insulin from the mother is not crossing the placenta, only the glucose is crossing. So what happens to the fetus? Fetus will think that is increased sugar in the fetus body. The fetus will start producing more and more insulin. So when there is more insulin in the fetus will become bulky. You'll have big babies, macrosomic babies, more than 3.5 kilos. So that is the reason in uncontrolled gestational diabetes mellitus, you will have big babies. Next slide. So this is how the blood glucose levels are maintained. When you eat food, the glucose is produced in the blood, and this glucose with the help of insulin enters the various tissues of the body. And with the help of insulin, the glucose is converted to glycogen and other things. On the other hand, suddenly, let us say you had breakfast at 8:30 in the morning, you're supposed to have lunch by 1:30, but you were not able to eat, you were traveling or busy with a meeting. It went up to 4 p.m., it went up to 5 p.m. Suddenly the sugars drop in the body. That is called hypoglycemia. When the sugar levels are dropping in the body, glucagon comes into picture. It is basically a switch. So there are two switches. One in switch is insulin, the other switch is glucagon. So when the sugars are high, body switches on insulin. When the sugars are low, body switches off insulin and switches on glucagon. So when the glucagon is switched on, the glucagon converts glycogen and various other things into glucose. Next slide. So this is one more slide which shows the basic physiology of insulin and glucagon. You can see insulin is being produced by the pancreas, which is a leaf-shaped structure. And this particular insulin will bring down the glucose levels in the body by preventing gluconeogenesis. You can see the right side panel on the top. Gluconeogenesis is being prevented. Glycogenolysis is being prevented, but glycogen synthesis is going up in the liver. The same way, there is increased glucose uptake in the adipose tissue, and there is decreased free fatty acid release. And in the muscle, glycogen is increased. So insulin is building up glycogen in various stores, in various places of the body. Next slide. Glucagon does the opposite. Glucagon increases the blood glucose, it increases gluconeogenesis, it increases glycogenolysis, it increases lipolysis. So both act opposite to each other. That is the reason, not in India, in Europe and in US, when a particular person is having diabetes, especially type 1 diabetes, which is quite often seen in young people, the treatment for hypoglycemia is a glucagon injection. In India, we don't have glucagon injections in practice, but in US, suddenly when a person is having low sugar, they just give a shot of glucagon so that immediately the sugar levels will go up. Next slide. So yes, coming to the main thing, what is diabetes? Very simple. Diabetes mellitus is a chronic disease. It's a long-standing disease where the major fuel of the body, the carbohydrate, is being misutilized. What do you mean by misutilized? The carbohydrate is not being properly utilized. Glucose is levels are going up in the body, and because of that, there is a disturbance in the fat and protein metabolism. So if you want to define diabetes, diabetes mellitus is a persistent, long-standing disease where utilization of carbohydrates, fats, and proteins by the body is disturbed, leading to very high levels of blood glucose, or it is called scientifically hyperglycemia. Why do we have diabetes? This occurs because the body is not able to produce enough insulin due to decreased functioning of beta cells in pancreas. This is what classically happens in type 1 diabetes mellitus, or else body is not able to utilize insulin properly because of insulin resistance. That is what classically happens in type 2, or it can be a combination of both. Next slide. So types of diabetes, basically we were able to identify three different types of diabetes. Type 1, where there is no insulin. Type 2, where there is insulin but which is not working. And gestational diabetes, which is seen during pregnancy. And the most common type of diabetes is type 2 diabetes mellitus. But I just want to inform one thing. Today, as of now, in 2020, we were able to identify more than 20 different types of diabetes. We no more have three types, we have more than 20. So the diabetes treatment, diabetes diagnosis is changing rapidly in the world. We are trying to involve genomics into diabetes. So we have various genetic forms of diabetes like MODY, maturity onset of diabetes of the young, which runs in families. Each and every person in the family will develop diabetes by the age of 30, 40, and many of them will be requiring insulin. The same way we have fibrocalcific pancreatic diabetes, where there are stones in the pancreas. Because of that, you are going to get diabetes. We have exogenous, like steroid-induced diabetes, which is called secondary diabetes. Now, in COVID-19, every week we are seeing more than 10 to 20 newly diagnosed diabetes mellitus patients. All of them never had diabetes in their life, but when they got admitted because of COVID-19, when they were given drugs like dexamethasone, they started developing diabetes mellitus. So we have various types of diabetes, which may not be apt to discuss now, but whenever we have time, we'll discuss regarding the various other types of diabetes. But you can remember these are the main types of diabetes: type 1, type 2, and gestation. Next slide. So what is basically happening? It's a key and door or key and lock mechanism. Insulin is the one which is opening the door, and the glucose is entering into the door, into the tissue. That's the normal physiology. In type 1 diabetes, there is no key to open the door. That's what. And simply, when there is no key, the glucose levels will go up in the body. Next slide. And in type 2 diabetes mellitus, key is present, but the key is not working. We have the wrong key. We don't have the right key. So if you want me to tell in a better way, basically, uh, the way we have army, which who are fighting against terrorists in Kashmir or in the border, we have antibodies in our body. The antibodies fight against various viruses or bacteria entering into the body. So GAD is one of the antibody. So what is happening basically with the GAD antibody? Sometimes the army will get confused between the public and the terrorists. They are going to kill both public as well as terrorists. The same way in type 1 diabetes mellitus, the GAD antibody is getting confused between the beta cells of the pancreas and the bacteria or the virus which is causing some lung infection or foot infection or whatever it might be. So whenever a person suddenly develops a lung infection, suddenly develops gastroenteritis, the GAD antibody is produced to fight against that particular pathogen. Let it be the bacteria, let it be the virus. Apart from that, it is killing the beta cells of the pancreas. It is called molecular mimicry. It is not able to differentiate between the beta cells and the pathogen. So suddenly the beta cells are killed, there is no insulin, and all of a sudden the particular person is developing diabetes. That's what happens in type 1. In type 2, initially we have discussed the fat levels are increasing in the muscle and the liver, that is called insulin resistance. In spite of having enough insulin in the body, the sugars will go up because the insulin is not able to prevent the liver from producing glucose, and insulin is not able to push the glucose into the muscle. Next slide. Gestational diabetes is a completely different thing. And previously, we used to wait till 24 to 26 weeks of gestation and do the oral glucose tolerance test for high risk women. What do you mean by high risk women? Elderly primary, a woman becoming pregnant after 30 or 35 years of age. Second, a woman has a family history of diabetes. Third, a woman has a history of diabetes in the previous pregnancy. Fourth, the woman is quite obese. Fifth, woman has a history of polycystic ovarian syndrome or hypothyroidism in the past. These are all the high risk women. In the high risk women, we used to do the glucose test, but nowadays the protocols are quite rapidly changing. We're more and more seeing diabetes mellitus during pregnancy. One thing which you have to remember, diabetes mellitus in pregnancy is very, very important because of the fetus. If you're able to treat, pregnancy will be very much relaxed. There is no harm to the mother as well as the fetus. It is completely a treatable condition. Insulin remains the main treatment of choice. But if you're not treating the diabetes mellitus in the pregnancy, both the mother and the fetus are going to have the complications. Fetus can develop macrosomia, that is large size. The fetus can develop seizures, fits. Fetus can develop various electrolyte disturbances and various organ anomalies. But the important point here, which needs to be stressed, yes, we have treated the mother successfully, uneventful delivery happened, the baby was also normal. But the basic problem in gestational diabetes is the mother is going to develop diabetes in the future. Now, the mother's age might be 26 or 27 or 28. She had gestational diabetes mellitus. After that, sugars became normal. We are relaxed. But this particular mother should be very, 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 what do you say? She should keep on checking her sugar in the future. She is at risk of developing diabetes quite early, maybe by the age of 40 or 45. So that is the basic importance of gestational diabetes. Next slide. So this is what insulin resistance means and beta cell dysfunction. Initially in type 2 diabetes mellitus, because of insulin resistance, even though the pancreas is producing insulin, it is not working. And over a period of time, pancreas becomes overburdened. So pancreas will be thinking, I'm producing more and more insulin, even though the sugars are not coming down. Then at one point of time, it gets strained. It will think there is no point in producing insulin. Suddenly the pancreas will be shut down. That is a time where the sugars will go up to 300 or 500. So, and second point, if you don't treat the diabetes properly, if you don't treat it aggressively, the beta cells will slowly decline. So 2020, the person has diabetes. We're not giving proper care. We're not treating the person properly. By 2025 or by 2026, the person will completely become insulin dependent. I'm talking about type 2 diabetes mellitus. So type 2 will start behaving like type 1 if you don't treat them properly. Next slide. So this is a famous theory postulated by Dr. Ralph DiFronzo. He coined the term ominous octet. Octet means 8. So he wanted us to understand 8 various pathophysiological defects that can lead to diabetes mellitus. If you see, if you start with pancreas, there is a decreased insulin production in the pancreas. That is the reason diabetes happens. Second, there are hormones like GLP-1, glucagon-like polypeptide, which are also important for diabetes. And in diabetes mellitus, these hormones are not produced properly. That can also result in diabetes. And adipose tissue starts producing more and more fatty acids. That is called lipolysis. That can also result in diabetes. And initially, what happens? There is a small door in the kidney. It is called SGLT2. So glucose is very, very important for us. Initially, kidney is filtering each and every glucose molecule. But as glucose is essential, kidney reabsorbs the glucose through a back door. In diabetes, what happens? There will be increased reabsorption of glucose through kidney. In the same way, muscle will not take up the glucose properly, and there can be a neurotransmitter dysfunction in the brain, and liver starts producing more and more glucose. And not only that, we have alpha cell dysfunction. What do you mean by alpha cell dysfunction? We know that beta cells are not producing insulin properly, or the insulin is not working properly. Apart from that, alpha cells are producing more glucagon. So when there is more glucagon, there will be more glycogenolysis, there will be more gluconeogenesis, and there will be more blood glucose. So these are the various defects that can happen that can result in diabetes mellitus. Now we have identified 14 defects. So I have moved from ominous octet to faithless 14. Next slide. So what are the various risk factors? Now we just limit our discussion to type 2 diabetes mellitus. We're not going to discuss much about type 1 and gestational diabetes mellitus. So why is it important? The importance of today's class is because you young minds, nutritionists, dietitians are more important than doctors. You are the face value. When a particular person comes to know that he or she is having diabetes, the first question that comes into their mind is, what should I eat? What should I do? Rather than when to consult a doctor. They don't believe in medicines. All of them believe in diet. So dietitians are very, very, very important people to deal with diabetes. They are the backbone of diabetes treatment in India. So you should have apt knowledge regarding diabetes mellitus so that you can identify people who are at risk of developing diabetes in the future. You might be having a neighbor who is obese, who is working in a software company, who is having night shifts, who smokes, who drinks alcohol. You can talk to him. You're having risk factors for developing diabetes. Get your HbA1c tested, modify your diet, modify your lifestyle. So that is the reason we're having this session. So these are the various non-modifiable risk factors. Risk factors, we have two types. One is modifiable. The second is non-modifiable. Non-modifiable, you cannot do anything. Age, you cannot change the age. You cannot go back. So any age of more than 40 is a risk factor for developing type 2 diabetes mellitus. Whether the patient is lean or person is lean or obese, more than 40, they can develop diabetes. If they have a family history of diabetes, they can develop. Ethnicity, Indians. So initially I told Indian Asian phenotype, we are at risk of developing diabetes. And if a person is having either impaired glucose tolerance or fasting glucose, I will explain to you later what are impaired glucose tolerance and fasting glucose, they can develop. If the person is having history of gestational diabetes in the past, they can develop. If they have PCOS, they can develop. Acanthosis nigricans, you can see in this picture, it is a black pigmentation that is seen on the nape of the neck, in the armpits, on the elbows, near the knee. So it is a sign of insulin resistance. So if a particular person is having pigmentation, it means to say insulin is not working properly. So they can develop diabetes in the future. The same way hypertension and dyslipidemia. So these are the various non-modifiable risk factors for developing type 2 diabetes mellitus. Next slide. So these are the various modifiable risk factors: overeating, binge eating, irregular lifestyle, obesity, inactivity, stress, and all these things. So if you're able to take care of these risk factors, I don't know whether you know the levels of prevention we have in any non-communicable disease like diabetes, obesity, hypertension. We have postulated various levels of prevention. We have a primordial prevention, primary prevention, secondary prevention, tertiary. So to make sure a particular person is not developing any of the non-modifiable risk factors of diabetes is called primordial prevention. So make sure everyone is having healthy lifestyle. They're active. They're not developing obesity. They're not having stress. Obviously, they'll not develop any of the non-modifiable risk factors like dyslipidemia or hypertension or IGT or IFG. Next slide. So what are the classical symptoms of diabetes? We call them as 3 Ps: polyuria, that is frequent increased urination; polydipsia, that is increased thirst; and polyphagia, that is increased hunger. But nowadays, we're not seeing any of these symptoms. Many of the middle-aged men and women who came to know that they have diabetes. They came to know because of general routine checkup. They are working in a software company, like let us say Wipro or Infosys, and a part of package they will undergo some medical examination once in a year. And when they do examination, HbA1c will be 10%. They will be hale and healthy. They will not even have a single symptom. So that's what India is suffering now. That is the reason India is going to become the global capital. We have so many people, unidentified people with undiagnosed diabetes mellitus in India. As of now in India, 6 out of 10, 6 out of 10 are prone to develop diabetes in the future. That is a very big problem which we need to deal with. Next slide. So these are the various other symptoms of diabetes: unexplained weight loss, easy fatigability, frequent infections, and when they have wounds, the wounds will not heal properly, and blurred vision. Blurred vision in the sense they keep on changing the specs. 1 week before they have changed the specs because vision has decreased. Again this week they need to change the specs and all these things, and tingling, numbness, and all these things in the hands and feet. Next slide. So why do we need to treat diabetes? Why are we so much concerned? Let the sugars be high, let the HbA1c be high. Because diabetes remains the most important cause of mortality in the world. According to a census released by the WHO, which we are going to see in the next coming slides, it is one of the most important factors behind death. It is one of the top 10 causes of death. Not only that, it causes stroke, it causes heart disease. Stroke and heart disease are the leading factors of death in the world. It not only causes all these things, it will affect your eyes, it will affect your kidneys, it can affect your heart, it can affect your feet. If you leave diabetes untreated, you are going to have all these complications. I just want to give an example here. We have two people, Mr. A and Mr. B. Both of them developed diabetes at the age of 30. Both have the same weight, same lifestyle. They are the best friends. They eat the same, and they work in the same company. They got diabetes by the age of 30. Mr. A took it very seriously. He brought down his sugars in the next 3 months. HbA1c came down from 10% to 6.5. Mr. B did not take it seriously. He continued to have high sugar. He was busy earning money. He wanted to earn money. He wanted to buy a flat, house, car, and all those things. They retired by the age of 60. After the retirement, Mr. A never had any issues. And after the retirement, interestingly, Mr. A's sugar started shooting up. His HbA1c went up to 7, 8, 8.5, 9. He started taking insulin as well. Even then, Mr. A will have an excellent life. Whereas Mr. B started having all the complications. Let it be the eye, let it be the kidney. He started undergoing dialysis. He lost one of the eyes. Why? Because the initial few years of your diabetes life are very, very important. As early as possible, if you're able to bring down the sugars, the each and every cell in the body has a memory. It is called metabolic memory or glycemic memory. The cell remembers, okay, he got diabetes by 2020, he brought it down in 3 months, sugars became normal. So the cell will be thinking the sugars are normal. But if you don't bring down the diabetes as early as possible, the cells will be thinking that you're having high sugar forever. After 20 years, even though the sugars are under control, the cells will behave in such a way that the body is still having high sugar. So it is always very, very important for all of us to remember that when we see a person having diabetes, we should go for aggressive early therapy so that sugars will come down. They will have a better life in the future. Next slide. So this is the global picture. You can see the various colors here. I'll just try to explain. The bottom color, the purple one, is the world population. And the color next to the purple population, the red color, is the Southeast Asia, where India and China are representing. This is a census taken from 2017. The numbers are represented in millions. Southeast Asia represents 82 million of the diabetes population in the world. So more than half are present in India and China. Throughout the world, we had 159 million people suffering from diabetes in 2017, of which 82 million are present in India and China. And what is the projection in 2045? 183 million is a projection in 2045. I'm talking about the total number of people suffering from diabetes in the world, of which 151 are going to be from India and China. So that is the basic problem we are having. You can see the remaining countries, it remains the same almost, but India and China, it is going to increase like anything. Next slide. So where is India standing? As of now, India is second to China. So this is again a census taken in 2017. India had 72.9 million, approximately 73 million people suffering from diabetes, whereas China had approximately 114 million suffering from diabetes. But 2045 projection, India is going to overtake China. India is going to become the global capital for diabetes. India is going to become a big sugar factory. Next slide. So the last part of our discussion, diagnosis of diabetes, how to diagnose. These are the various lab criteria. When you check a fasting plasma glucose, if it is more than or equal to 126, it is called diabetes. And when you do a oral glucose tolerance test and check the 2R value, if it is more than 200, it is called diabetes. And when the A1C is more than or equal to 6.5, it is called diabetes. Or when the random plasma glucose is more than or equal to 200, and the patient is having symptoms of diabetes, it is called diabetes. Next slide. So again, the same thing, fasting, plasma glucose and OGT. Fasting is usually done after 8 hours of fasting. Let us say the patient finished his last meal or last snack at around 10 p.m. in the night. We check the sample at around 6 a.m. in the morning. And postprandial usually done after 2 hours after the meal. And OGTT, what do you mean by OGTT? Postprandial, the patient will have idli, dosa, or vada and come back and give the sample. OGTT, what is happening? We have a doubt regarding the diagnosis of diabetes. We ask the patient to come to us. We'll collect a fasting sample after 8 hours. We'll give 75 grams of glucose in 1 glass of water, let us say 100 ml of water, and take one more sample after 1 hour and one more sample after 2 hours. And we'll check for the values in these three samples. Fasting more than 126, 1 hour more than 155, 2 hours more than 200, it is called diabetes. Nowadays, we don't do OGTT much because it's quite cumbersome, but it remains the gold standard test for diagnosing diabetes. More than fasting and postprandial, OGTT always is best. Next slide. HbA1c. HbA1c is a very, very, very important marker for diabetes. So nowadays, especially in COVID-19, we're not giving much importance to fasting and post-meal because patients are fearing to go to a diagnostic lab and give the blood. So we are asking them to get one HbA1c done. The advantage with HbA1c, what do you mean by HbA1c? It is called glycated hemoglobin. The lifespan of red blood corpuscle in a human body is around 100 to 120 days, approximately 3 to 4 months. So in the RBC, we have hemoglobin, and the hemoglobin is getting attached with glucose. We have HbA, HbB, HbC, HbF. These are the various types of hemoglobin. So we're going to find out how much of glucose is getting attached to HbA. When you calculate that particular factor, it comes in a single or double digit value. It gives approximately and roughly the picture that happened over the past 3 months. Let us say today we did a HbA1c on 13th of October. So whatever happened in the month of September, August, and July will come to know. So the first advantage of HbA1c, it gives a long-term picture. Fasting and PB depend on that day and the previous day. Previous day, patient did not eat junk food. Patient was fasting. Fasting can be low. And on the day when the patient gives sample, the patients are quite intelligent. When they visit a doctor, they'll just have to idli. But in the home, they'll have chicken biryani. So you will not get a proper postprandial value. Whereas HbA1c is taking into consideration 3 months. So the patient cannot deceive us. Second factor, HbA1c can be done at any point of time. No need to be on fasting. Even it can be done in the morning, in the afternoon, in the night. And third, HbA1c has 3 different values. Any value less than 5.6 is normal. More than 6.5 is diabetes. The value between 5.7 to 6.4 is called pre-diabetes. So today after the session, I just want to influence each and every one of you. You should take it as a main message from the session. Go back to your home, If you come across any person more than 30 years of age, let it be your brother, sister, uncle, aunt, anyone, neighbor, ask them to get one HbA1c done at least once in 6 months to once in a year. This should be a drive that should happen in India as of now. Why? Many of them will be having HbA1c of 5.8 or 5.9 or 6, that is between 5.7 to 6.4, which is called pre-diabetes. If you leave them like that, they are going to develop diabetes in the future. It can happen in 6 months, 1 year, or 2 years. So if you're able to identify a person having HbA1c of 5.7, person is obese, hypertension, dyslipidemia, do something. Modify the risk factors. Bring down the HbA1c to 5.4. By doing so, you're actually helping that particular person and you're decreasing the burden of diabetes in India. Next slide. So if anyone asks you regarding the importance, what test should be done, you should always say HbA1c rather than fasting and plasma. Fasting and plasma glucose, these are the various parameters that need to be followed while giving fasting and plasma glucose sample. Patient should be on 8 hours fasting, and the value post meal should be done after 2 hours. They should not smoke, they should not drink, they should not do exercise, they should continue all the regular medications. There is a one common question which many of us is a common scenario, especially people coming from places like Tumkur or places like Kengeri, and the lab is in MG Road. They need to travel. Then sometimes there can be a traffic jam. Patient, instead of reaching the lab by 6 a.m. or 7 a.m., they might be ending up late. They might be reaching by 8 a.m. or 9 a.m. So it becomes a prolonged fasting. The common question asked by many patients, can I have something? Yes, usually they're not allowed to have anything except for water. In such cases, you can ask them to have one glass of milk without sugar. Next slide. So for HbA1c also the same thing, no fasting required, and it can be given at any point of time. It is a more reliable test than the fasting and post meal. Next slide. Yeah. One more important thing, nowadays we are going beyond HbA1c. The recent concept now which we have is called time in range. HbA1c no doubt gives a 3-month average. Now the latest advanced diagnostic tool that is available with the doctors is time in range. What do you mean by time in range? Usually we give a target of fasting 80 to 120 for a person having diabetes of a normal age, and after the meal 120 to 160. On any particular day, 70% of the values should be between 80 to 160. That is called time in range. Maybe in the near future, after 10 years or 15 years, you'll be seeing each and every doctor asking for time in range rather than HbA1c. The time in range concept is beyond the scope of this discussion. We'll discuss regarding that later. So this is called the tip of iceberg. So why did I include this thing? You can see the tip. The tip is the one which we are seeing when it comes to diabetes in India. So the people who are diagnosed with diabetes, people who are going to get treated for diabetes represent the tip. But the bottom, you can see the submerged part of the iceberg that represents the actual number of people having diabetes in India, who are undiagnosed, who are silent. We don't know about them. Next slide. So how will you identify a person having a risk for developing diabetes? Yes, today's class was good. You went back and you want to know, okay, every person is having obesity, every person is having dyslipidemia, but there should be a scientific way to know which person is going to develop diabetes, which person is at increased risk. For this, we have developed a score by name, Indian Diabetes Risk Score. Can we have the next slide? The slide may not be clear. I will just mail you the slides again. There are various factors taken into consideration like age, abdominal obesity, physical activity, and family history. Each and every factor has been given a score. Example, age. If age is less than 35, the score is 0. If the age is between 35 to 49, the score is 20. If the age is more than or equal to 50, the score is 30. The same way we have given scores for abdominal obesity, physical activity, and family history. And you take all these scores, you calculate the total score, the minimal score comes as 0, the maximal score is 100. If a particular person's score is more than or equal to 60, the person is at high risk for developing diabetes. If the score is between 30 to 50, it means the person is having moderate risk. If the score is less than 30, person is having very low risk for developing diabetes. So you can start utilizing this risk score for identifying people at high risk for developing diabetes. In the same way, we have a vascular score for heart disease. So you can start utilizing that one as well. So these scores are very, very important when you do general diet counseling to each and every patient. Next slide. So can diabetes be cured? It may not be, we may not be able to cure the diabetes completely, but we can keep the diabetes under control with the help of healthy diet, lifestyle, and proper and timely medication. The patient can live long life with diabetes. One thing which is an important factor in a particular study, we came to know that if a person is having diabetes, if he or she is able to keep it under control, they're going to live longer than a person not having diabetes. Recently, we celebrated 100th year birthday for a person having diabetes. He is having diabetes for the past 60 years. He developed diabetes by the age of 40. He lived happily till the age of 100. He's now living happily as well. And believe or not, his brothers died, his children died, his friends died, but this gentleman is hale and healthy. So many of them, especially people having type 1 diabetes, will get depressed, will get stressed. I developed diabetes, I can't eat this, I can't eat that, my kidneys are gone, my eyes are gone. Should tell them nothing like that. If you're able to consult a doctor, if you're able to take a proper diet advice, if you're following a healthy lifestyle, and if you're keeping the things under control, you're going to live longer than a person not having diabetes. Livable diabetes, eating on time, sleeping on time, walking, doing exercise, all these things are good aspects of each and every person on the earth. So this is what you should counsel every person having diabetes. So if you have diabetes and if you are able to keep it under control, you can live long and healthy life. Next slide. So can it be prevented? Yes, if you're able to identify the modifiable and non-modifiable risk factors, if you're able to implement the risk score, you can identify the population at high risk for developing diabetes. And when you act early and when you give them excellent counseling and advice, you can prevent the diabetes in that particular population. Next slide. So this is the mantra as of now we are following. You should run fast and you should eat slow. You should eat fruits and you should drink vegetables. Next slide. And this is what I just wanted to share with you. The census released by WHO. You can see diabetes remains one of the top 10 causes behind mortality in the world. And the leader for deaths in the world is ischemic heart disease, that is heart disease. And the main reason a particular person develops heart disease is diabetes. So directly or indirectly, diabetes still remains one of the leading causes for death in the world. Next slide. Can diabetes be reversed? Next slide. Next slide. So I just want to finish off today's discussion with a case presentation. We have seen one 30-year-old housewife who developed diabetes after the pregnancy. During pregnancy, she had diabetes. This happened, if I'm right, in June 2018. She delivered a baby boy. And she came to us in December 2018 with very, very high sugars. And she was not even having a single symptom. Out of interest, she got tested because she thought I'm having diabetes. I had diabetes during pregnancy. Why don't I get one more test done? So she got tested in the month of December. HbA1c was more than 13 or 12%. And she had a very strong family history for diabetes. Both the parents were having, uncles were having, aunts were having, cousins were having. So we were not sure it can be a case of Modi. Next slide. So what happened? Her BMI was normal. She was little on the overweight side. Her BP was normal. She had no acanthosis nigricans. GAD antibody was negative, so it cannot be type 1. She had a very good amount of C-peptide, meaning to say that insulin is still present in the body. But if you look at the HbA1c, it was 13.2%, meaning to say over the past 3 months, December, October, and November, her average blood sugar was around 300. And fasting on that day was 349 and post meal was 421. Next slide. So it was became very difficult for us to convince her to take insulin. She told us throughout the pregnancy I was on insulin. I don't want to take insulin. So we counseled her. We told her various. We gave her various examples where the patients took insulin, were able to stop the insulin, and we told her regarding this particular person who lived for 60 years with diabetes and who was able to keep his health under control, and we were able to inspire. So she took it very seriously. We started her on treatment, and we started on insulin and oral drugs. She went back to home. We even fixed a device onto her arm which kept on checking her sugar. Next slide. So you can see this particular device. It started working from 10th October 2018 to 22nd October 2018. Believe or not, within 15 days, her HbA1c came down from 13% to 6.1%. So goal number one achieved. Sugars have come down. Next slide. You can see the red color thing. The red color thing is the low sugar. You can see on 22nd October, I have placed an arrow over there. She started having low sugar. So what we did, we had to stop the insulin. Insulin was stopped on 21st of October. Next slide. And sequentially, drug number 1 was stopped on December 2018. Drug number 2 was stopped on Jan 2019. Drug number 3 was completely, that is metformin, was stopped on March 2019. So for the past 1 year or so, she is not even taking a single drug for the treatment of diabetes mellitus. Next slide. Recently, during the lockdown, she got her HbA1c done. Can you imagine what is HbA1c now? It is 6.8. In spite of not taking a single drug for the treatment of diabetes mellitus, she was able to keep her sugars under control over the past 18 months. And she has sent the logbook to me. You can see the fasting 113, 113 after the breakfast, 107, 160, and 196 after the dinner. And she was uh, genuine enough to mention that she had some junk food on the day. But what I wanted to say, this is a classical case to uh, prove that if you're able to treat diabetes in an intense way as early as possible with the help of insulin and all the oral drugs, the sugars will come down. And after that, when the patient starts following a regular diet and lifestyle, the sugars can be kept under control without medications. So I'm not sure whether the diabetes is reversed in this particular case or not. We're closely following up this lady. But this is an example where diet and lifestyle play very, very, very important role. So you can tell any person that if you're getting treated in a proper way, if you're following diet and lifestyle, you can not only stop insulin, you can even cut down the medicines, and you can even stop the medicine at one point of time. So the recent concept is within the first 6 years of diabetes, if you're able to treat it in an intense way, there is a chance of reversing it. So we're trying to establish this particular theory. We're not sure about this, but when you come across any person having diabetes, you should counsel them. You should give a positive feedback and positive influence, and you should tell them, don't worry about these medicines. All the medicines don't have any side effects. Medicine treatment for diabetes is only temporary. It is not like hypertension or cholesterol or hypothyroidism where you start a medicine, you cannot stop it. In diabetes, we can cut down the number of medicines. It doesn't mean if you start a medicine today, you need to continue that medicine forever. So you should change the mindset of the particular person so that they can cut down the number of medicines in the future. By cutting down the medicines, actually are controlling diabetes. Next slide. So the take-home summary, the number of diabetes population is going up in India, which is going to become the global capital in the world. Type 2 diabetes is the most common type of diabetes, and the major chunk of diabetes is because of type 2. Type 1 even remains a challenging type of diabetes. And the various risk factors for diabetes we have studied, let it be the modifiable and non-modifiable risk factors for diabetes. And we have an Indian diabetes risk score, which can be used to identify a person at risk for developing diabetes. And we have studied about various diagnostic tools, let it be the fasting plasma glucose, 2R or OGTT, and HbA1c, which can be used in diagnosing diabetes. And we have studied about various symptoms of diabetes. And lastly, we have studied about the importance of treatment, early and aggressive treatment for diabetes. Thank you very much.
Thank you, sir.
By any chance, did we overshoot the time?
No. We are on time only. We are within the time. You started and finished.
Yeah,
Yes.
in initial, there was not any
This,
disturbance initially.
after leaving that, no, we are on time only.
Okay, thank you.
Yeah. Can we take some questions or?
Yeah, please, you can.
Okay. Lakshmi, can you stop sharing the slide?
Before stop sharing, sir, I would like to have one query related to PP. You have shown that slides. Can I just go back, sir?
Yeah, please.
1 second. That 8 reasons you have shown, no, sir? That octet.
Ominous octet.
Ominous octet.
Yeah, can you just explain that incretin?
Yes. Can you go back on the slide?
Down.
A little bit up, I think.
Further. I mean, I think 20. Yeah, come down, Lakshmi. Yeah.
I think here.
Yeah. So basically what happened, you want to know further about the incretin effect. So in the 1900s, the scientists have observed one particular interesting phenomenon. If you're able to, when you give IV glucose to a particular person, the sugars, let us say after giving 100 grams of glucose through intravenous route, through a vein, the sugar will be some 100 in the body when you check the blood. The same 100 grams of glucose, if you give orally, instead of giving IV, the sugars are actually coming down. You understood the concept now?
Okay.
When you give sugar IV and when you give sugar orally, there is a difference in the blood sugar. So the blood sugar will come down when a particular person is taking sugar orally instead of giving the sugar IV. So that missing link between IV and oral is called incretin effect. So they were able to identify few substances called incretin hormones, which are produced by the gut. So when a person is eating food, the hormones in the gut are produced. These hormones are going to bring down the sugar. What these hormones do basically, they will go and tell the pancreas to produce insulin by acting on the beta cell. They will go and tell the pancreas to not to produce glucagon by acting on the alpha cell. And the same gut hormones are telling the brain, they will induce or increase satiety. Okay, you had 2 idli, enough, don't eat 3rd idli. And the same hormones are acting on the kidney, they're acting on the liver, they're acting on various other tissues, and they will stop further production of glucose. So it took a while for us from 1900 to 1990 to identify these hormones. They're very, very good molecules. But the problem with these hormones, they're very, very short acting. They will act for only 2 minutes or 3 minutes. So now we started producing these hormones outside and in the form of injectable therapy. And we started giving this to the patients. So they're one of the treatment options for diabetes. And one tablet has come into the market. Maybe next year it is going to come into India. It is called semaglutide. The name is Ribelsis. So if you take this tablet will become this hormone. It will act for a week. You can see the difference. Naturally, these hormones are acting only for 2 to 3 minutes. But this particular tablet, which is an analog of the hormone, will act for a week. And for a week, it is going to produce all these pleiotropic effects. Am I clear?
Yes, sir. Thanks. Because now students are learning about the ghrelin, leptin.
Exactly. So these hormones, so they are the ones which are going to affect the ghrelin, leptin, neuropeptide, and all these hormones. So they are going to play with the satiety and appetite. They are going to act on the brain.
Okay. Thank you, sir. Thanks.
So this is the same as GLP and GIP,
Yes,
no?
these are the same as GLP-1 and GIP. Now we have the recent GLP-1 semaglutide that is coming to the Indian market in the near future. It is going to change the treatment of diabetes like anything. So when we have a discussion on the management of diabetes, we're going to stress upon these things.
Oh.
Maybe in the 3rd session or 2nd session, if I'm right.
Yes, sir.
Okay.
Sir, I have a question. Now, when you take HbA1c, no, what if the person is anemic?
Very good question. So that is a problem with HbA1c. When a person is having anemia, we can either get a falsely low or a falsely high value. So then we have other tests like fructosamine. So which the difference between fructosamine and HbA1c is that fructosamine, we're going to test the amount of glucose present on the amino acids. So
Okay.
fructosamine may not give the 3-month picture. It might give the 4 weeks picture. But in such cases, HbA1c may not be a right tool to assess the diabetes. Fructosamine and other things like 124 anhydroglycitol. These are few tests which are available with very few labs. We can do those tests. Especially in pregnancy, we don't do HbA1c. In pregnancy,
Okay.
the RBC turnover is very rapid. So
Okay.
HbA1c becomes unreliable in pregnancy. Especially in pregnant women, we either do a OGTT or we go for fructosamine test. So in a person having spurious anemia, that is low hemoglobin, HbA1c becomes unreliable.
Okay. Thank you, sir.
Shefali has message, since my family has a history of diabetes and if I develop diabetes by the age of 21, what is the next thing to follow? Can it be a case of Modi? Yes, Shefali, it can be a case of Modi. And what are the next 10 things to be done? First thing, we have to treat you like any other, you in the sense a person developing diabetes at the age of 21 with a very strong family of diabetes like any other person. What we can do further, we can do a genetic analysis. We can search for a gene in that particular person's body which can cause diabetes, and we can search for the same gene in each and every family member. The importance of this test is when the particular person is conceiving in the future, when she is getting married or he is getting married, and when they're giving birth to children, and let us say the person is having Modi, a gene is positive. The gene mutation caused diabetes. And in the kid, when the kid is 1 year or 2 year or 3 years old, we're going to check for the same gene. If the kid is having the gene, then we have a proof to say that the kid is going to develop diabetes by the age of 20. So when the child becomes 20, we're going to do the HbA1c regularly. We're going to modify the risk factors. And instead of developing by the age of 20, we'll make sure the child is developing diabetes by the age of 50. Do you want me to take up the remaining questions as well?
Yes, 1 or 2 questions if you can, no? All students are asking these questions.
Yes.
Turn your video on.
Yeah. Shall I read the questions in the chat box?
Yes, yes, yes.
So Shristi was asking, is it possible for some medication to induce a type of diabetes? Yes. Steroids are known to induce diabetes. That's what I was telling. During COVID-19, we started seeing new cases of diabetes mellitus because of steroid therapy. It is called steroid-induced diabetes. And there are few other drugs like antipsychotics, which are given for the treatment of depression and psychosis, like clozapine and or clonazepam and fluoxetine. All these things can induce diabetes. Certain beta blockers can induce diabetes. So there are few drugs which can induce diabetes, mainly steroids. And Rashmi Ji was asking, are there any side effects of getting glucagon shots? If I'm right, she has mentioned glucagon, but glucagon shots, there are no side effects in type 1 diabetes mellitus. Glucagon shot is given especially in an episode of hypoglycemia. Sometimes the sugar value can drop as low as 40. The patient becomes unconscious. In such a case, if you're able to give a glucagon shot, immediately they will recover. Shefali was asking, if a person has liver cirrhosis and tuberculosis with diabetes, what is the role of diabetes in the drug medication? Very important question. Not only liver cirrhosis and tuberculosis, even if they have chronic kidney disease, many of the oral drugs that are given for the treatment of diabetes may not be helpful. We don't usually give the oral drugs. In such cases, we have very limited options to treat diabetes. Number one, insulin becomes the main therapy. Second, the values of the targets completely change, because in cirrhosis and chronic kidney disease, they are more prone to develop low sugar. So the treatment may not be stringent and intense. For a normal person having diabetes, if the fasting target is 80 to 120, for a person having liver cirrhosis, the target will be 100 to 140 to prevent hypoglycemia. Any other questions?
Sir, can I ask one question?
Yeah, please, ma'am.
Okay. The GDM you were telling, no, sir, and this may go, from glucose may travel to the child, and the child in future can get diabetes. I mean, the risk factor is high.
Yes, ma'am. If the, no, actually what happens if the glucose definitely is traveling to the child, the fetus, but if you're able to keep the mother sugars under control, and if the child's birth weight is normal, the child is not going to have a future risk of diabetes. He will have a risk of, he or she will have a risk of diabetes because mother had diabetes,
Ah, okay,
not
okay.
because the child had increased levels of glucose in the body during pregnancy. But if the sugar remains uncontrolled throughout the pregnancy, and the child was born with a very heavy weight of more than 3.5 kilo in Indian setup, definitely that particular child is going to have a risk of diabetes in the future. Now we started even asking for the birth weight of the patient. Many of them may not be remembering that. We had an experiment happened in CMC Vellore known as Vellore Birth Cohort, VBC. What they did, they captured the birth weight of a particular population 20, 30 years back. They started following up them for 20 to 30 years. What they were able to identify, a person having an increased birth weight, they were not able to identify whether the mother had diabetes in pregnancy or not. Just they captured the birth weight. So if a person is having increased birth weight during pregnancy, I mean after, during the delivery, the fetus, the child, that child is going to develop diabetes in the future. The risk is more.
What is the birth weight? I mean, more
In
than
Indian,
3.5
in
or?
Indian, 3.45 is the cutoff that was decided by Dr. Seshaya. So he
Okay.
did a very good experiment in India. So in Indian setup, macro that is called macrosomia. In
Okay.
Indians, macrosomia means 3.45 or anything more than 3.45.
Even if the mother is not diabetic, if the child is 3.5
Yes,
and more.
yes, correct.
Okay, fine. Okay, sir. Okay. Thank you. So
Any
I
other
think
questions?
many will have questions. We will store the questions for tomorrow, I mean, day after tomorrow and later two
Yes.
classes.
I will make sure I will come early and I will join early without any
Yes, sir.
technical
Yes, sir.
issues.
So 4:30 we will join on day after
Fine,
tomorrow, sir.
fine,
That is on
fine.
Wednesday.
Thank you, thank
Okay.
you,
Thank
thank
you
you.
so much, sir.
Thank you very much and thank you, Mary ma'am. I could hear both of you after a long time.
Where we as usual, you will always tell the stories, and that makes us remember. And it is so contagious, Dr. Chaitanya. When I take class also in diabetes, my batch of students, Miriam and all, Palak and all, who attended your classes, they say, ma'am, you've got the same tone as Dr. Chaitanya.
Nice to know about that.
Yeah,
Thank you,
and
thank you.
another thing is they were very grateful to you because they learned the medication, and when they attended the interview during this COVID time for a job, someone asked them how come a nutritionist knows so many medication in diabetes, and then they messaged that ma'am, we are so grateful that doctor exposed us to all these medication names. So
Thank
they
you,
were
thank you.
thankful, and all of them are also employed in this diabetic area only after
Thank you.
UG itself.
Very good, very good. Nice to know about that. I'm happy, so happy. Thank you, ma'am. Thank you once again.
Thank you, sir. So really it is like a story and enjoy. It's not we are hearing some class. It's like just gets into your memory brain, like we can say.
Bali ma'am, just
Yes.
one last question. I don't know. Chetna, she messaged me privately. The question is, one Chetna, her son's birth weight was 3.9. I have not having diabetes during and after pregnancy. So is my son is at risk? So I think some relative of some student. I don't know, ma'am.
Yes. Not like they're going to develop diabetes, the particular child immediately. In the future, after the child becomes 20 or 25, better to get all these HbA1c, everything done, and better to maintain a healthy lifestyle. And one more important fact is childhood obesity. Now, irrespective of the birth weight during birth, we are seeing more and more childhood obesity cases in India. So this particular child, whatever Chetana was asking, make sure the child is not having childhood obesity. And when the child enters age of 20-25, follow whatever precautions that have been taught.
Okay, thank you, sir. Okay, ma'am. I think we'll wind up. Yeah.
Yes.
Sir, you can send the PPT in next session, no? If you have any.
Sure, definitely. I will do that. I will send beforehand. Don't worry.
Thank you, sir.
Okay. Thank you, sir.
Thank you, all of you.
Thank you, sir.
Take care. We'll meet day after tomorrow.
Yes, sir.
Thank you. You can interact next class. Just
Sure.
store your questions. We can have interaction with sir.
Definitely. Thank you very much. Thank you, Lakshmi ji. Thank you very much.
Yes, yes. So next time, whenever the diabetic course is floating, please let us know because
Yeah, definitely. I will update you. There was a disturbance this year around because of COVID, but next time I'll update you.
Yeah,
So you're still doing it for this Dr. Mohan's diabetic educators course.
Oh, actually, ma'am, the Mohan's Diabetes Educators Core, they made it online. They had some issues. I think, yeah, if I'm right, we had a discussion regarding that. So this time around, I was not a part of that. I have voluntarily withdrawn from that because some issues happened internally. But next time they are going to modify it. They are going to streamline everything. And maybe next year by Jan or something, they are going to have one more session. So whenever there is a session, new session, I will update you.
Okay, sure. Because a lot of girls ask me.
Yes, ma'am.
Okay.
We'll do that, definitely.
Yeah.
Okay.
Thank you, sir.
Thank you very much. Take care.
Yes, sir.
Okay then. Bye-bye.
Ma'am, shall I end?
Yes, you can end the event, Lakshmi.
Okay.
Yeah.
Okay. Thank you. Thanks, everyone.